This is Health UnaBASHed, broadcasting live on Healthcare Now Radio. Health UnaBASHed is a conversational platform where healthcare meets innovation. We engage top industry talent and dive into the heart of health and wellness, from vision to business model, to bring you the latest developments in health tech, to promising AI applications, policy, and ultimately impact on the public's health and well-being. I'm Gregg Masters, co-host, executive producer, and I'm joined by the digital health aficionado himself, author, editor, global thought leader, and in his executive capacity, steward servant, Gil Bashe. On today's menu, we are in the company of Dean Ornish, MD, the founder and president of the nonprofit Preventive Medicine Research Institute in Sausalito, California, and serves as clinical professor of medicine at the University of California, San Francisco. Dr. Ornish authored 6 best-selling books, including the New York Times bestsellers, Dr. Dean Ornish's program for reversing heart disease, Eat More, Weigh Less, Love and Survival, and his most recent book, The Spectrum. So, Gil, with no further delay, Mike is yours.
Gregg, I want to thank you once again for the gracious introduction. It's always a pleasure to be working with you. And just to our listeners, Gregg and I are going to be doing some very special work together. Gregg, as many know, he lost a son not too long ago in a traumatic accident, and his condition deteriorated in the hospital, and was overlooked. And Gregg and I will be speaking in the coming weeks about the fragmented health ecosystem, and does it serve the aspirations of the healers, the doctors and the nurses who tirelessly want to help patients? Is our system really serving their and our patients' best interests? So, Gregg, our thoughts, of course, go out to you, and I'm looking forward to chatting with you. You know, we have so much going on in the health system, and today we have an incredibly, incredibly special guest, Dr. Dean Ornish. Many of you know Dr. Ornish because of his best-selling books, his appearance on countless morning news shows, his interviews in pretty much every single major newspaper and magazine in the United States. Dean has been on, actually well known on 2 presidents' advisory groups. He's been on an advisor to President Bill Clinton and to President Barack Obama. And actually, he's working still with the White House in different ways. Dean has also served as the personal physician in many regards to President Clinton after he was diagnosed with his coronary artery disease and had his bypass surgery. Dean was there as a friend to President Clinton and as a clinical advisor to the president. What many people overlook, and I've never overlooked, is that Dean Ornish is a scientist. And he has been really at the forefront of how food is medicine and the science around that and lifestyle, our behavior, our mindset, our approach to life, our zest for life. He's been looking at that for more than 3 decades. I had the privilege of meeting Dean. He wouldn't remember it, but I remember the meeting quite well. It was in South Carolina. It was at a theater there. And it was at the first offshoot meeting of TED, Technology, Entertainment, and Design. I was invited as an attendee. There were 200 attendees in this theater audience. Dean was, of course, a keynote speaker up there talking about his research and science of diet and coronary artery disease. And he immediately caught my attention. I said to myself, this is a person who will change the face of U.S. health. I remember also, I don't know, Dean, if you remember, they actually served food from Dean's first, I guess, his first cookbook. They actually prepared the food according to the Ornish diet, which has been ranked, I think, consistently, perhaps by U.S. News and World Report, as the finest, most comprehensive, the diet program with the best healthy outcome of all diet programs. I think Dean has made food science accessible, and that's why they call him the pioneer or the father of lifestyle medicine. He's more. Dean, welcome to the program. What an honor to have you with us today. You have really been in the forefront of this for decades.
Well, thank you after that kind introduction. Maybe I should quit while I'm ahead.
But you can't.
But I do want to say in all seriousness, Greg, I'm so sorry about your son. I can't think of anything worse than that. So heartfelt condolences.
No, Dean, I've got to say you were raised in Texas. You obviously went to medical school at Baylor, one of the great medical schools of our nation. You shot up to Boston. I think you did maybe a residency in Mass General, and then you stayed for a bit at Harvard Medical School as a fellow in medicine. But I've got to ask you, someone as expansive as you are in medicine, why preventive medicine? Why become, in essence, an internist? You could have sort of, jumped into neurology, cardiology, or anything. Why preventive medicine?
Well, there's an old saying, prevention is better than cure. An ounce of prevention is worth a pound of cure. And I think that's true. And lifestyle medicine is using lifestyle changes not only to prevent disease, but to treat and often reverse it. And what I've learned over the last 40 some odd years, 46, 7 years of doing these studies is that our bodies often have a remarkable capacity to begin healing, and much more quickly than we had once realized if we can treat the underlying cause. I had a cartoon drawn back when I was an intern of doctors busily mopping up the floor around a sink that's overflowing, but nobody's reaching to turn off the faucet. And I got interested in doing that when I was learning how to do coronary bypass surgery at Baylor College of Medicine in Houston with Dr. Michael DeBakey, who pretty much invented the procedure. He was also kind of an old school tyrant, the kind of guy who would stick you with a needle if you didn't move your hand fast enough out of the operating field. And I remember he said, "What year are you, son?" I said, "I'm starting my third year." He goes, "Damn, it's going to be so much harder to bust you out of here with all these weird ideas you have." So it was a challenging several months there. But he called me actually about 4 years ago after decades. I hadn't heard from him literally in 30 years. And he said, "Hey, Dean, this is Mike DeBakey." And he had this very distinctive Louisiana accent, which I recognized immediately, even after all these decades. And I said, "To what do I owe this honor?" He said, "Well, those weird ideas I used to give you such a hard time about when you were my medical student?" I said, "Yeah, I remember really well." He goes, "That's what's kept me alive all these years." He said, "I'm 99 years old. I'll be dead soon. I just thought you'd like to know my wife got interested in your work and it really helped me." So, I guess if you live long enough, things come full circle.
You've had an influence on so many people's lives. I know that I don't know if they've reached out to you or you were kind enough to reach out to them. You shared with me not too long ago a story that about President Clinton, that when his bypass started to occlude, you jumped in and helped him and guided him through the process. He looks great, by the way. I pray that he's healthy. He is always brilliant. I've had the pleasure of meeting the president and chatting with him. He's part of one of the sharpest people I've met, and one of the most expansive people I've met. And you were his physician. Obviously there's a patient-doctor privilege, but from the example or what he's allowed you to share publicly, and I know you stay in close contact with the president. What could you share with us that you kind of shared with him that has kept him healthy, thankfully?
Well, I take confidences and physician-patient confidentiality very seriously, but these were things he's talked about publicly. I began working with him shortly after he was elected president in 1993, and Hillary Clinton asked me if I would train the chefs that work for them, that cook for them at the White House and then later at Camp David and the Navy Mess and Air Force One and so on, which I was happy to do. And then when he had his annual physical, I was one of his only non-military doctors that would come in for that, which was a real privilege and an honor. And after his bypasses clogged up, one of his cardiologists went on CNN and said, "Oh, it was all in his genes and his diet and lifestyle had nothing to do with it." But having worked with him for many years, I knew that it had everything to do with it. So I sent him a note and said, "Look, it's not all in your genes. Your genes are not your fate. If it were, you'd be a victim, and you're not a victim. You're one of the most powerful guys on the planet." That we'd done studies with Craig Venter showing that our genes have switches that can turn them off and on. They're different proteins called sirtuins or histone and non-histone proteins and methylation and so on. And in effect, if you can turn off a gene that causes people to get sick, there are certain biological mechanisms that are common to a wide variety of the most common and costly chronic diseases. And my wife Ann and I wrote a book called Undo It a few years ago that put forth this unifying theory that the reason why these same lifestyle changes can beneficially affect so many different diseases that they're not really so different, that they all share certain common biological mechanisms, things like chronic inflammation, oxidative stress, changes in telomeres and gene expression and angiogenesis and immune function, overstimulation of the sympathetic nervous system, and so on. And each of these mechanisms, in turn, is directly influenced by what we eat, how we respond to stress, how much exercise we get, and how much love and support we have. So I sent the president a note and said, that your genes are not your fate. And I say this not to blame, but to empower you, because if you can do something about it, then you're not a victim of biology, that our biology is a predisposition, but it's not our destiny. And so we met not that long after, and he really got serious about changing his lifestyle and has been now for quite some time and is doing quite well. And so, again, whatever your political persuasions are in this increasingly polarized world we live in, when a former president, especially one that was known for, in his own words, jogging to McDonald's, makes these changes, I think that sets a great example for everybody.
Yeah, along those lines, first of all, thank you for your great work, and I'm confident that the president and Mrs. Clinton or Secretary Clinton are appreciative to you, tremendously appreciative.
Yeah, I'm going to be seeing him later this evening, so we're still in touch.
Well, I think it's because it's not just your scientific acumen. You're just a great person. Anybody who has contact with you picks up the fact that everything you do comes from a place of deep caring about people. I think that had you stayed in Texas, you would have been an incredible family physician. But I'm glad for the nation that you decided to go to Harvard, and then obviously you're in the one of the capitals of health innovation on the West Coast. So we all benefit from that. I wanted to ask you
By the way, Texas is where the word shit is a 3-syllable word. So
good to know. Good to know. That will be shared. No, but I also wanted to ask you, we spend $4 trillion a year in the United States on health. We spend during COVID, it was more, it's gone back down, but we kind of religiously spend about 18% of GDP on health. That's still about 2 times what most developed nations spend. And I don't want to exaggerate this, but I'm wondering if, because you're so expansive in your medical knowledge, there's a part of me that wonders, is it because we gave up what you hold so dear, preventive care, and we kind of shifted into a sick care system, which is, hey, you do what you want to do. You'll get sick, and I've got a pill for that. I've got a tablet for that. I've got a surgical procedure for that. Hey, if you have occluded arteries or clogged arteries, not a problem. I'll cut you open and take care of that. I'll put a stent in. All of this is about not preventive care. It's really about sick care management. So I do know that we spend about 11% of that 18% on drugs. And we spend about 52% of that on hospitals and doctors. The rest of the 30 some odd percent that's left over, who knows what we spend it on. But I'm wondering, is it the cost of health in this country, how much we pay literally for health care, or is it really the cost of sickness? Is sickness our biggest expense as opposed to investing in, well, you call it lifestyle medicine? Is that a better return on investment for America?
Well, clearly, 86% of the almost $4 trillion we spent last year on healthcare is mainly sick care for treating chronic diseases, many of which can be not only prevented, but often even reversed by making more intensive changes in diet and lifestyle. A whole foods plant-based diet, moderate exercise, meditation, and social support. Eat well, move more, stress less, love more, to reduce it to its essence. And, the more studies we do, the more we've shown how these, people think, oh, diet and lifestyle, that's kind of boring. How powerful could that be? It's got to be a new drug, a new laser, a new device, something really high tech and expensive. And I think our unique contribution has been to use these very high tech, expensive, state of the art scientific measures to prove how powerful these very low tech and low cost interventions can be. When somebody gets put on drugs to lower their cholesterol or their blood pressure or their blood sugar, and they say, doctor, how long do I have to take these drugs? What does the doctor usually say? Like forever. If we go back to the cartoon of the doctors, busily mopping up the floor around the sink that's overflowing and nobody's turning off the faucet. Like, how long do I have to mop up the floor? Like, forever. Well, why don't we turn off the faucet? And when we do, and the faucet, the underlying cause, are to a much larger degree than I and most people had realized, are these lifestyle choices. That these biological mechanisms are very dynamic in both directions. You can get better quickly, you can get worse quickly, and they're directly responsive to the degree of lifestyle change. So when the paradox is when you change a lot of things in your lifestyle all at the same time and you make big changes, sometimes it's actually easier than just taking a pill, even though that's counterintuitive, because when you take the pill, it generally doesn't make you feel better, but the lifestyle changes do. And in the case of someone with heart disease, their chest pain or angina often goes away, usually within days to weeks. And for somebody who can't go back to work or make love with their spouse or play with their kids or walk across the street without getting chest pain, and then within a few weeks, they can do all those things. Then they say things like, I like eating cheeseburgers, but not that much. I like not having pain even more. What I gain is so much more than what I give up. And quickly, it makes it much more sustainable.
Just dropping in, you're right on time for Health Unabashed on Healthcare Now Radio. We're chatting with Dr. Dean Ornish, the founder and president of the nonprofit Preventive Medicine Research Institute in Sausalito, California, and who serves as clinical professor of medicine at the University of California, San Francisco. Stay tuned for the rest of the story.
People don't realize it wasn't just perspective, it was research, hard research you did with patients and peer-reviewed clinical trials, published data. You've been published in, I think, a Lancet, in American Journal of Cardiology. You've been published in JAMA. This is not just work you did with Ann Ornish in the kitchen. This is work that you did, with other clinicians around the United States to take a look at patient health. And I'm just curious if you could share. I know you've had great successes, such as the Center for Medicare and Medicaid Beneficiary Services, CMS, actually giving a reimbursement code for the Ornish Lifestyle Program on one hand. And then on the other hand, you have professional organizations, I won't mention any names, but while they have primary disease prevention guidelines, often including diet and exercise, I think they find that less sexy clinically. So they kind of go to the next stopgap, which is secondary prevention, which is high cholesterol, take a statin. High blood pressure, take a calcium channel blocker or an ACE inhibitor or a beta blocker or something like that. Are we making medicine in a way too easy? In other words, are we sort of saying, gee, instead of drilling down and acknowledging to the nation, we need to get serious as a nation about primary care? Are we just saying, just write a script for 90 days, 90 days worth of tablets and be done with it? And I'll see you in 6 months or see you in a year.
Well, we're trained to use drugs in surgery. We're reimbursed to use drugs in surgery. So we use drugs in surgery. The average doctor, I'm on the nutrition working group of the American College of Cardiology. We published a paper a few years ago. The average physician gets 4 hours of nutrition training a year. And the average cardiologist in 4 years of fellowship gets none. So, it's not surprising that, Abraham Maslow once said, if the only tool you have is a hammer, you tend to see everything as a nail. And of course, pharma companies love drugs that you have to take forever. Cholesterol-lowering drugs, diabetes medication, blood pressure drugs, now the latest, the GLP, weight loss drugs, because that's, they make billions and billions of dollars from these drugs. Now, again, we've all benefited from drugs in surgery. They can be life-saving when used appropriately. But particularly in terms of many chronic diseases, they don't usually treat the cause. So that's why you have to take them forever. You have to keep mopping up the floor, so to speak. So I like doing research. It's hard doing these studies, particularly randomized trials. It's hard to get them funded, for one thing, because everything we've done, people thought was impossible at the time. When we showed for the first time that heart disease could be reversed, people thought the best you could do was slow down the rate at which you got worse. Much as people view Alzheimer's today, we showed if you make bigger changes and a lot of things at the same time, that we could often reverse the progression of heart disease. So we could redefine what's possible. But to do those studies, before people realize that, it's a bit of a catch-22. Without the funding, you can't show it works. They don't think it works. They don't want to fund it. So we have to kind of raise the money as we go along, which is kind of a crazy way to do a study because you never know if you're going to have to stop in the middle of it. But it was the only way we could do that. And so, but the reason why I do these studies is that, properly done and working with the top collaborators and top scientists in the world, we can redefine what's possible. And by doing so, we can give hope, real hope, not just false hope, to millions of people at this point and provide them with new hope and new choices that they didn't have before. The other thing that I learned, though, was that good science, while it's important, is not usually sufficient to change medical practice. Again, we're trained to use drugs in surgery. We're reimbursed to use drugs in surgery. So I thought, when we published our studies, randomized trials in the leading journals, it had some effect, but not as much as I'd hoped. And then I realized that, if you really want to change medical practice, you have to change reimbursement. And again, it's not because doctors are only interested in money, but we have to make a living, have to pay our mortgage, and that's how we're trained to do. So I thought, we first went insurance company by insurance company, and that was hard because most people don't go into the insurance world because they're, innovative or entrepreneurial. So I thought, gee, if Medicare could cover it, then that would really be kind of a game changer. I had no idea it would be so hard. We had Bill Clinton when he was president, but also Newt Gingrich when he was Speaker of the House. One of the few things they came together on. We had Charlie Rangel, a very liberal Democrat, and Dan Burton, a very conservative Republican. In fact, Charlie Rangel and Dan Burton and I did lifestyle medicine seminars in the House. Something that probably wouldn't happen today. Things are so much more polarized, even though they were then. But it worked. And so, but it took 16 years with all of that. But Medicare did finally create a new benefit category to cover our program, for which we're deeply grateful, and it made a huge difference. And then when COVID came along, they started covering it when we offered it by Zoom. If anything good came out of COVID, it was learning that it worked just as well when we did it by Zoom as when we did it in person. I thought incorrectly that it was too high touch, but it turns out I was wrong. It worked just as well. So now we can work with people instead of having to just train hospitals and clinics in our program. You had to live near one of those to benefit. Now you can live anywhere, anywhere in the world, really. But you can live in rural areas, you can live in food deserts, and even people who live near a hospital or clinic we train often couldn't afford to take off work or get childcare or didn't want to come to the hospital and get exposed to COVID. And now they can do it from the comfort and privacy of their own home. And that helps reduce health inequities and health disparities and makes it available to everybody, which is so great. I also just want to clarify, you kind of mentioned that Anne was in the kitchen while we're doing this work. Anne while she's great in the kitchen, spends most of her time. She developed the learning management system for our program. She's helped design our studies. She's, a
She's a true partner. She's a true partner in the work.
In everything that we're doing. But that's why I like doing these studies, is that they can redefine what's possible. We've shown that with these same lifestyle changes, because they share the same mechanisms, could reverse type 2 diabetes, high blood pressure, high cholesterol, obesity, early stage prostate cancer, lengthened telomeres in a study we did with Dr. Elizabeth Blackburn, who got the Nobel Prize for discovering telomeres, the ends of our chromosomes that regulate cellular aging. As our telomeres get shorter, our lives get shorter, and the risk of all these diseases goes up proportionate to that. We found for the first time that if bad things make them shorter, good things make them longer. These lifestyle changes that we've been studying actually increase telomere length. We showed that for the first time. And we're about to publish the first randomized trial showing that these same lifestyle changes to see what the effect are on people with early stage Alzheimer's. We know what's good for your heart is good for your brain because they share a lot of the same underlying biological mechanisms. And I can't really talk about it yet until it comes out. By the time this airs, it may have come out, but perhaps not. So I can just say that we're cautiously optimistic about our findings. And since my mom and all of her siblings died of it, I have one of the ApoE4 genes myself. This can really also potentially give many people new hope and new choices.
In the brief time we have left, I wanted to explore that. Often people are frightened of diagnosis and illness, so they use the fear to say ignorance is bliss. And I think what you and Anne have really sort of reinforced for preventive care is that in the case of heart disease or certain cancers, or in this case, cognition potentially, that engagement around your diet, your lifestyle, your mindset, your well-being is is number one preventive care. Engage, engage, engage. Is that correct?
Yeah, a lot of people don't want to know. There are tests available now. First of all, you can see if you have one of the Alzheimer's genes. There's a study that just came out today in Nature that people that have both of those genes are almost, it used to be thought they had an 8-fold increased risk. It's more like 100% of people are likely to get some version of that. But what we now know is that, and a lot of the tests that are coming out using artificial intelligence and others can often diagnose up to 10 years before people become clinically symptomatic if they're likely to get Alzheimer's. But a lot of people say, why would I want to know something so terrible? When you lose your memories, you lose everything. Why would I want to know that if I'm likely to get something that's so awful that medicine can't do anything about it? At best, they can slow it down a little bit. So a lot of people don't want to know. But if we were to show that many people could improve their cognition and change the course of the disease in beneficial ways, then it probably works even better to prevent it. We know that the earlier you intervene with Alzheimer's, the more likely, whether it's with drugs or lifestyle, the more beneficial the effect is likely to be. But there are no drugs that can even stop the disease from getting worse. There have been billions of dollars spent on developing these drugs over the last 20 years, and only 2 drugs have been approved in 20 years. One got taken off the market last month because it didn't really work very well, and the other one doesn't really work that well either. It just slows it down a little bit. It's $26,500 a person, plus other costs of MRIs and CT scans and so on, and almost 20% get horrible side effects like bleeding into your brain. So if we were able to show that lifestyle changes can slow, stop, or perhaps even reverse the progression of early stage Alzheimer's, the implications for prevention may be equally important, because that may motivate people to find out if they're likely to get it. And if they are, that in turn might inspire them to make these changes to a much larger degree than they might otherwise need to. And the more lifestyle changes you make, the greater the impact are. That's what we found in all of our studies over 45 years. The more you change, the more you improve. But to reverse a chronic disease, you have to make really big changes. That's why we were the first to prove that in so many different areas, because most people didn't go far enough.
Well, we've just heard probably some of the most critical information our listeners can recognize in the course of the year. An ounce of prevention is worth pounds of cure. And Dean, I want to thank you and Anne for the incredible work you're doing in the research. I'm looking forward to reading, of course, your study on cognitive health, reducing the risk of Alzheimer's disease. I think this is going to be another great chapter in your contribution to people's health throughout the nation and throughout the world. Dean, thank you so much for joining us today on Health UnaBASHed.
Gil, Greg, thank you. You're raising awareness as well, and awareness is always the first step in healing. So thank you.
Well said.
And that, dear listeners, is the last note for today's melody. A huge thank you to our worldwide audience for tuning in, and a tip of the hat to our special guest, Dr. Dean Ornish, the founder and president of the nonprofit Preventive Medicine Research Institute in Sausalito, California. Stay social with Gil and me on Twitter by Gil_Bashe, and that's BASHE. And Gregg Masters, MPH, and that's Gregg with 2 G's. And don't forget to give your tweet some zing with our hashtag HealthUnaBashed. Until we meet again, pursue your passion for better health and with no apologies.